Good morning, everyone. My name is Andrew Gangemi. I'm a assistant professor of medicine at the Lewis Katz School of Medicine in Temple University in Philadelphia, Pennsylvania. I'm one of the co-editors for the Journal Club for the Clinical Problem Assembly here at the ATS. I want to thank all of our panelists today. We have a very esteemed group to discuss the recent publication in the Blue Journal. We're joined by Dr. Eihab Bedawi, who is from the Sheffield Teaching Hospital with the NHS Foundation Trust. We'll be joined shortly by his co-author, Dr. Najib Rahman, professor of respiratory medicine at the University of Oxford. And then as part of our expert panelists, we have Dr. David Feller-Kopman, who's a professor of medicine at the Geisel School of Medicine at Dartmouth Hitchcock Medical Center in New Hampshire. Today, we're going to be discussing the publication Video-assisted Thoracoscopic Surgery or Intrapleural Enzyme Therapy and Pleural Infection, a Feasibility Randomized Controlled Trial. This is the third multicenter intrapleural sepsis trial, or the MIST-3 trial. And with that, I'm going to pass the screen over to Dr. Bedawi to talk about his research.
Thank you very much, Andrew, for the kind introduction, and thank you for the invitation to the organizers, really, for giving us the opportunity on behalf of myself and Najib for presenting this study. I'll just get my screen up, and hopefully you can see this okay. Andrew or David, if you could just give me a thumbs up if you can see the slides. Yeah, perfect. Excellent. Okay, great. So I have no conflicts of interest. Just to set the scene, what I'm going to do is I'm just going to go through some of the relevant background, because I'm accepting or assuming rather than that some of the audience may be more general rather than necessarily a pleural or IP oriented audience. So pleural infection is a condition that we continue to see very commonly in respiratory practice. It is one that when we pull together all of the epidemiological data recently in the literature as part of this ERS-ESTS task force, we found that really, regardless of whether you take the data from the US or the Europe or the UK, the trend is in a rising incidence, and this is quite concerning. Why is this a problem? Because this condition continues to be associated with a high morbidity. The median length of stay is long at 10 to 14 days, and a significant proportion of these patients end up needing additional treatment, either in the form of surgical treatment or intrapleural therapy. It's also expensive because of these interventions that are required, and is actually one of the highest, it's the highest, most expensive acute lung illness, and certainly amongst pleural disease. So this is a high financial burden to healthcare systems as well. And sadly, if you come, if you're a patient admitted with pleural infection, you and I see you at the front door, you have a 1 in 5 chance of not surviving the year. And this is something that we've been sadly unable to change in the last 10 to 20 years. So where did this all start? This started with the MIST-2 study, which was published at the beginning of 2011. And this was led by Najib Rahman, who's co-presenting with me today. And this was a double-blind, placebo-controlled randomized trial of 214 patients with pleural infection with 4 arms: placebo, TPA DNAs, and TPA DNAs combination. And what it showed, that it was the TPA DNAs combination that had superiority in improving chest X-ray opacification, not only compared to placebo, but also compared to monotherapy with either the fibrinolytic or the enzyme. So this created the beginning of the evidence base for combined intrapleural fibrinolytic enzyme therapy, what I'm now going to be referring to in the rest of the talk as IET. Importantly, not only did it improve the radiographic opacification, but it also showed the reduction in need for surgical referral, as well as a reduction in length of hospital stay. Now, obviously, at the time, this was 52 patients in a randomized controlled trial, so it needed to be bolstered by more real-world data. And what we found recently was that there were 627 patients now in the literature from these 9 studies that have supported the results of the MIST-2 study, showing this pooled treatment success, which a lot of these authors define as surgery sparing, rates of approximately 90%, evidence that it shortens length of stay, improves the chest X-ray clearance. However, there was still significant concerns that it hadn't really been properly road tested in terms of its safety. And certainly when this Cochrane meta-analysis was published in 2019, it did suggest that more data was required regarding serious adverse events, as there is uncertainty of whether fibrinolytic therapy is associated with with more morbidity. So we recently published this paper in Chest with the help of friends in the US and IPOG. And what we did was, this was a collaboration of 25 centers, and we looked at basically the largest series of pleural infection patients treated with intrapleural enzyme therapy with pleural bleed that was predefined as a change in either the pleural fluid hematocrit or 25 to 50% serum hematocrit when the clinician suspected that there was a bleed. And what we identified 76 bleeds in the series, and the results were remarkably similar to the MIST-2, giving an overall incidence of pleural bleed of 4.2%. And not only that, we also showed that 2/3 of these patients actually do not require surgical or pleural intervention. More than half of them required a blood transfusion. A significant minority were resolved with conservative treatment alone, and the ones requiring serious intervention were very, very low, 1.3%. However, this treatment is associated with significant pain, and it is important for us to acknowledge that not only in our clinical practice, but also when we're critiquing the quality of this treatment, because obviously to be able to complete the course, you need to be able to comply with the treatment course, and obviously pain is a significant barrier to this. So we've shown that this treatment works. We've shown that it's safe. So what are the gaps in the evidence base? We haven't actually shown that intrapleural therapy improves mortality. We haven't shown that it improves quality of life. We haven't sort of evaluated how it affects time to complete recovery, resolution of pleural thickening, or lung function. And obviously the elephant in the room is it better than surgery? And what are we losing, or what are our patients losing rather, by us directing them to intrapleural therapy rather than to our surgeons? And also the other thing that I wanted to explore was, why have we suddenly decided that surgery is bad? And is surgery sparing? Is this a patient-centered outcome, or is this a convenience outcome to us and our surgeons and our healthcare systems? And I think this is really important. Now, if we look at the comparative RCTs for surgery, they are small. They are often have methodological flaws with regards to the high tube failure rate that you see in the medical arm. They're often a highly selected population. If you look at the median age, for example, in these studies, compared to, for example, unselected randomized controlled trials such as MIST-2, it's 45 versus 61. So not really representative of a lot of the patients that you and I see in clinical practice. There was a lack of blinding and no objective decision-making criteria, and I'll come to that a little later on. But what there is, I think, a case for exploring early surgery, because if you look at more recent data, and I reference this paper by Tao et al., this is the largest series of VATS empyema in the literature to date. This is from American data from the Society of Thoracic Surgery. These are patients, 4,000 odd patients who underwent VATS for empyema, and they showed really good results in terms of low conversion rates, really low 30-day mortality. And actually the main risk factor for conversion, the data tells us, is actually a delayed referral from us to them. And very strikingly, actually, what they showed in this data was that each preoperative hospitalization extends the mortality by 1.2x. And when this goes to beyond 5 days, you see much more occurrences in readmission, prolonged stays, discharge to transitional care, etc., etc. So the key really is that we need to refer these patients early. And obviously one of the challenges that we have in pleural infection is these patients often present late, usually have slow burning symptoms going on for weeks, sometimes get inappropriately, or not improperly, I think mistakenly, directed towards cancer pathways due to the similarity in sort of weight loss, loss of appetite, and not presenting with typical sepsis that is easy for front door clinicians to pick up. So we come back to this scenario where we've got two treatments now. We've got VATS surgery, which surgeons have a technique that surgeons have improved, developed experience in, and is showing good outcomes. And intrapleural therapy, which following on from the MIST-2 has built a strong evidence base. So is it us as physicians and our intrapleural therapy, or should we really be referring these patients to surgeons? So really the only way we could answer that was the MIST-3 study, and this was really the first ever attempt at trying to directly and prospectively compare these two treatments in a head-to-head randomized controlled trial in an unbiased way. And the way we designed this study was that we took patients with pleural infection, as per standard diagnostic criteria and international guidelines. We treated them with standard care for up to 24 hours. And the important, what we wanted to do here was to exclude the quick responders that don't necessarily go on to need more intervention without necessarily delaying those that do for too long. So because the key here is early escalation. We then randomized all comers, and we took a gamble here because we wanted obviously to account for the selection bias of the previous studies and use the most unbiased approach that we could. So regardless of fitness for surgery, we randomized all comers to one of three arms: early VATS, standard care, and intrapleural enzyme therapy. And the main outcomes that we were looking for here was feasibility of recruitment, acceptance of randomization, feasibility of data collection, and we analyzed this as per intention to treat. Now I'm going to preempt one of the questions that's going to come in the discussions, which is why a standard care arm, if clearly the comparison here was IET and early VATS. And the answer to that is really quite simple, which is basically at the time that the MIST-3 study was being set up, most guidelines still recommended that standard care with good medical treatment with chest tube and antibiotics was sufficient to treat about 60% of the patients. And our funders basically insisted that we have this as a control arm. So this is why the trial was designed in this way. We recruited across 8 sites in the UK, and you can see here that we had a good geographical distribution of these studies, and we were also keen to incorporate sites that had a combination of on-site and off-site surgery, because this was important in terms of the generalizability and applicability of the study towards a wider healthcare system. And I just want to quickly touch on this concept of medical treatment failure, which we were quite keen for centers to adopt as an objective decision-making criterion within our study protocol, because obviously you and I may have different opinions of whether a patient needs surgery or not, but I think if we all agree that if a patient has a residual and clinically significant pleural collection on imaging as a radiological parameter, and then a clinical parameter where they have ongoing evidence of sepsis, either with fever, tachycardia, low blood pressure, and a biochemical parameter, and then you needed to have 2 out of 3 of these to meet the criteria to then be randomized. And this is something that all the PIs in the study had to demonstrate that the participants met before they were randomized. Again, why did we do a feasibility study? This is a question that Naj and I get asked quite often, because I think to be able to do a head-to-head definitive study, obviously we would need a lot of participants, we'd need lots of centers, and we would be really, in terms of making sure that we're asking the right questions. What we have a sparsity of in pleural infection is the ability to understand what are the key outcome measures. We've never actually done that before. What do our patients want from pleural infection? So we wanted to make sure we were asking the right questions, establish the right outcomes, to make sure that we could actually recruit in the first attempt at a surgery versus non-surgery trial in a big multi-center setting. Make sure this was acceptable to our participants, and not only our participants actually, but would it be acceptable to physicians and surgeons as well? Because this is something that at least recently hasn't been done this way. And obviously to assess our ability to collect outcome data, and we also included the qualitative sub-study to be able to do a deep dive into patient perspectives and really understand the patient experience, not only through the usual treatment of pleural infection, but also going through a trial such as this as well. And our main feasibility criteria were to successfully randomize more than 50% of eligible patients, to retain more than 95% of these to discharge, to be able to collect essential outcomes, and retain more than 80% of them to at least a 2-week follow-up. Okay, so I'll come on to the results now. So how did we get on? We screened 178 patients. Out of these, 110 patients met our eligibility criteria. We excluded 13 of these for being quick responders, so that left us with an actual eligibility rate of 97 patients, and we randomized 60 patients in total. And the highlight here was that we met our feasibility criteria. Randomization rate was 62%. We were able to retain 100% of these patients to discharge, and 84% were retained to 2 weeks. Now, the eagle-eyed amongst you will have noticed that we randomized 60, even though we aim to randomize 75. And this being a journal club setting, I thought I'd share with you one of the most painful graphs of my my PhD and this study, which is our recruitment graph. And you will notice here that we started actually ahead of recruitment, recruiting above our planned trial. But then you will all remember that in March 2020, the COVID pandemic struck, and this obviously significantly hampered the rest of the trial. And interestingly, on that point, I mean, we were really curious to or keen to understand what was happening here, whether it was that centers just had to redirect all their resources towards urgent public health COVID studies, or whether there was a genuine COVID effect. So we did a retrospective analysis amongst the 8 of the centers that were recruiting, and interestingly, what we found was that there was actually a 33% reduction in pleural infection hospitalizations in the same period between 2019 and 2020, before COVID and post-COVID between 2020 to 2021. And you'll notice that it's particularly striking in this winter period here, where we normally see a peak in pleural infection studies that just appear to disappear. And we think this was probably a combination of the most vulnerable patients shielding at home, maybe some shared risk factors in terms of viral infections, and patients who get pleural infection. So I'll come on to the patient demographics, these were our main risk stratification. So we stratified the groups by age and by rapid score, which is the only externally validated risk stratification tool that we have in pleural infection. And you can see that there's a reasonably equally distribution amongst the 3 groups. And then if we come to treatment compliance, so these are the matching colors just to be able to understand the table. So in standard care, we had a poor compliance and about 48%. And really, this could be, I guess this was somewhat expected, and this was probably due to the fact that most of our centers had already started practicing ahead of guidelines, and acknowledging that a lot of these patients do need to be escalated beyond chest tube and antibiotics by day 2 and day 3 anyway. Within the intrapleural enzyme therapy, we did have better compliance at 79%, and in the surgical arm, we had compliance of 50%. And the reason IET and VATS is included here in this bottom row is because you were allowed to have intrapleural enzyme therapy as a bridge to surgery while you waited for your theater slot. So that is something that we allowed in the protocol, which we do in clinical practice anyway. Interestingly, when you look at the reasons for non-compliance, it was somewhat different to what we expected, and I'll explain why. So in the intrapleural enzyme therapy, we had 4 patients, and patient intolerance in 2 of them. This was simply due to pain and inability to complete the treatment. Clinician choice, and again, this was before the large series that we published in chest, but actually both of these patients won. Both of these patients were actually due to a concern about bleeding risk. One patient who had a bronchopleural fistula on CT and was on anticoagulation, and then another patient who there was concern about having a subdiaphragmatic connection. But if you look at the non-compliance in the surgical arm, the majority of these patients actually weren't that the anesthetic risk was deemed too high and these patients were fit for surgery. This was only a minority, about 10%, but the majority of these were actually clinician choice. So this was the surgeon who went to assess the patient and decide whether or not they were suitable for surgery. Now, there is 2 ways of looking at this. One could be that this is a perception that the patient doesn't need surgery, but I think at the time, it's important to remember again the times that we were in, and I find it hard to believe that this didn't really play a major factor in the recruitment. And this was the COVID surge collaborative data that had been published in the Lancet, and it was telling all surgeons that there was a very significant risk of postoperative pulmonary complications in up to 50% in anybody around that time. And the reality was that this was ongoing for most of the recruitment of the study. So this may have possibly biased this specific signal, and I imagine or in fact, I would go stronger and say I'm sure that surgical compliance would have been significantly better had this not been the case. And in terms of treatment-related adverse events, this was obviously an important part of our feasibility as well. There were 8. So there was 1 SAE for a major postoperative hemorrhage, but in terms of adverse events, the majority of these were actually related to pain, but very few other adverse events that we had to contend with. So that was quite positive. So that really takes us in terms of the primary results in terms of of feasibility. And if I may just quickly take you through a couple of the secondaries, just in terms of interest. What we looked at here was obviously time to intervention. And interestingly, what you see is that although there's a difference in time to intervention, 1 versus 3.5 days, when you compare intrapleural enzyme versus VATS surgery, the length of stay was interestingly the same. Now, obviously, we were not powered for this outcome, and I want to say that very clearly. But there is an interesting signal here that we can discuss later as well. If you look at the patient-reported outcomes, pain at 2 months appeared to be very significantly lower in the intrapleural enzyme therapy and met the minimally clinically important difference of 60 millimeters in terms of the VAS pain measurement. And also, if you look at the EQ5D5L Health Utility Index, for those of you who are not familiar with the EQ5D5L Utility Index, 0 is basically you feel equivalent to death. 1 is perfect health. And if you note, if you compare the baseline in 2 months in the intrapleural enzyme therapy, you start at 0.35. Actually, interestingly, IET and surgery are both very similar here, 0.35 and 0.38. But if you look at the improvement at 2 months in the IET arm from 0.35 to 0.83, and then the VATS surgery at 0.38, it goes up to 0.58. And this was statistically significant here as well. So in summary, we did meet the feasibility criteria. There were high levels of patient acceptability. We were obviously, aside from the COVID-related issues, we were pleased that when the patients were met and introduced to the study, there wasn't any difficulty in recruiting them, and there was high levels of patient acceptability there. There appeared to be a good degree of surgeon and physician equipoise. There was convincing evidence to remove the standard care arm, but the initial 24-hour drainage is clearly important and something that needs to be factored into future definitive studies and I would argue, any pleural infection comparative studies in this area as well. In terms of surgical compliance, only 10% refused due to anesthetic risk, but the majority of patients were due to a perceived improvement by the assessing surgeon. However, there appears to be a very interesting signal towards improvement in length of stay. Perhaps surgery is likely to accelerate discharge once it occurs. And in terms of the patient-related outcome measures, perhaps IET may be associated with a lot of pain at the beginning, but then goes on to be associated with lower pain and better quality of life and better recovery at 2 months. So this really sets us up nicely for the definitive study. If I'm just allowed 3 more minutes just to quickly introduce another aspect of this, I just wanted, because this was a really key part of this, is what is the optimal primary outcome in pleural infection? And I just want to give you the headline from some of this data that we're currently preparing in manuscript format. So when we looked at the qualitative data, one of the key things we wanted to understand is what are the important outcomes in pleural infection for patients. And interestingly, it wasn't avoiding surgery. It was getting the best treatment that gets me out of hospital quicker and doesn't need me to have more treatment again. It's the treatment that makes me get out of hospital the fastest. It's the treatment that stops me from dying. It's the treatment that causes me the least amount of pain, and the treatment that improves my quality of life and stops me from having prolonged symptoms. So these are really the key things that are important to patients, and things that I think any pleural infection study from now on should look at and evaluate in terms of its outcomes. So I will quickly introduce the MIST-4 study, which Najib and I are delighted to have had funded very recently, and are very excited to get started. What we've done is this is going to be a 2-arm study now, comparing early VATS versus intrapleural enzyme therapy. We've chosen to go with a primary outcome of treatment failure, but we're also going to be assessing length of stay as an important outcome, patient-related outcome measures, and obviously doing some health economic analysis as well. It's going to be a 1-to-1 RCT with IET versus VATS as first-line treatment in a similar way that we did in MIST-3, excluding initial 12 to 24-hour drain success. And we are going to have some degree, some criterion to mitigate against those those patients who are clearly not surgical candidates, using a clinical frailty score, which we've defined as being a CFS of less than 6. And the treatment failure primary outcome will be measured up to 90 days post-randomization. How will we define this? We're going to be looking for any further pleural intervention after the initial randomization treatment up to 90 days. So if beyond the treatment, if you have a further chest tube, you get more surgery, you need more intrapleural therapy, you get readmitted, you have to have reinitiation of antibiotics, or you die from all causes. And that's basically what we're going to be looking at. One of the best things about running a multi-center randomized controlled trial is you get to work with lots of great people, and there's really so many people to thank for getting this trial through during difficult times. So I just wanted to thank all the members of the trial steering committee, the trials unit, all the investigators, and thank you very much to you all for listening.
Thank you very much for that presentation, Ehab. And again, congratulations to you guys. I can imagine how difficult it was to recruit for the study, especially as you mentioned with the COVID pandemic and all the difficulties that that provided. So again, congratulations on this study and best of luck, especially moving forward with the MIST-4 trial. I'll start off with Dr. Feller-Cotman, just getting your thoughts in general in terms of where you see where you've seen the field in terms of the treatment for pleural space infections and where this trial is going to kind of lead us towards.
Yeah, so first off, huge congratulations to Eihab and Naj. Outstanding study. I think the take-homes that the big take-homes that I received from this is one, that publishing a feasibility study in a high-quality journal works. And also the purpose of research is to generate more questions. So you did a phenomenal job of showing that you can do this, especially during COVID. And now MIST-4 is going to hopefully definitively answer the question with the focus on patient-centered outcome measures. And that I can't really stress enough, and you did a great job highlighting that. In your slide, I'd love you to comment on, you showed 5 circles there of all factors that were quite important. And maybe you could pull that slide up again, because I think that's really crucial to think about when designing these studies. So you showed 5 factors that were very important to patients: mortality, length of stay, readmission and reintervention, pain, and quality of life. Do you have a sense as to which is most important? And then I'm also wondering if there's also a difference in geography. For example, patients in the NHS in England may not care about length of stay as much as Americans who often like one and done. So I'd just love your comments on that.
Yeah, thank you, David. So yeah, I mean the looking through the transcripts from the qualitative interviews was really interesting, actually. I mean, these were sort of half an hour to 40 minutes interviews where patients really went into a lot of detail about every single aspect of their experience, from presenting to the emergency department to the first treatment they had, the first doctor who spoke to them, the nurse who approached them about the trial, and it was really fascinating to read. And when you look at sort of these aspects, I think the length of stay is something that I think we've always kind of prioritized, because as clinicians we kind of feel that where our hospitals and our ward managers and whatever are always happy when we're able to provide a treatment that gets patients out of hospital quicker. I mean, I was actually quite surprised and somewhat pleased that somehow that does remain of importance to patients, and that did come up quite a lot. Patients don't like being in hospital. They say that they always prefer if there's an option for them to recover at home. That came quite strongly. I must say the pain aspect of pleural infection was particularly one that I hadn't thought of before. I mean, the mortality you would assume is somewhat obvious, but I think there's a lot of treatments, even from the initial chest tube, from the intrapleural therapy, coming out of theater, pain just kept coming back again, and patients just want to get back to, they want to get back to gardening, they want to get back to playing with their grandkids, they want to get back to work and eating and drinking, things like that. And I think to answer your question, the one that really struck me the most, and the one that we decided to go with for MIST-4, was this the fact that the only thing worse than getting an empyema and having to come into hospital is having to go home and come back again and have another treatment. And I think that seemed to come out really strongly in a lot of the transcripts. So that's probably the one that I think the patients will go with. And when we spoke to our patient and public involvement committee, this is the patient group that helped us design the study, and that we actually we consulted with throughout the MIST-3 and in preparation for the MIST-4. They all felt that really if you could tell every future pleural infection patients that patient that this is the one treatment that you know to go for that will give you the least chance of having to come back in and have another treatment, that is probably what they'd go for.
Yeah, and it's interesting because as we've seen as the literature has evolved, how common pain is in these patients, it brings me back to something that I learned many, many years ago, which is it's much easier to prevent pain than to treat pain. And because of that, I'll often prophylax pain with you know, 25, 50 micrograms of fentanyl, something like
Yeah.
that, with the hopes of decreasing the development of pain in the first place. So it would be interesting to see how that shakes out.
Yeah.
And also at this time, you know, as we're getting into some of the discussions, if there are any questions from the audience, you guys can enter them in the chat box, and I'll kind of funnel them to the panelists. The question I had kind of reading this and also thinking forward to the next step, and maybe this is for Dr. Bedawi and also Dr. Rahman. You know, with the MIST-3 trial, you guys had enrolled everybody across the spectrum of rapid scores, which, you know, for anyone not familiar, that's a kind of mortality scoring system or predicting system. But the lowest kind of rapid score, the mortality is somewhere in the realm of like 1 to 3%. From the data for the validation cohort. So, you know, with the MIST-4 trial, do you anticipate doing any kind of stratification in terms of the rapid score, or at least enrolling people in those higher rapid scores to show truly if there's a difference for people who are more likely to benefit?
Sure. Yeah, shall I take that one? Is that all right?
Yeah, go for it, please do.
So, Andrew, I think that's a great question. We need to be a bit careful with predictive scores. Let me explain why. Is there solid, prospective, validated data that rapid works? 100% there is. It's amazing how close the prospective study of nearly 500 patients was in terms of its predictive ability as the derivation and retrospective validation. So I feel very strongly that we know that low rapid, you've got a 3% mortality, and high rapid, you've got a 50% mortality. That's firm. The issue with most predictive scores in medicine is that it's not really that you can tell your patient, look, you're a bad one or you're a good one. It's really what you do with that information. And that's the missing piece of the jigsaw where rapid is concerned. So do I calculate rapid scores? Sure, I do, because it gives me some helpful information. What should or can we do with the rapid score? That's the key issue. So what you're implying, and I think it's a good implication, is that the low rapid score patients, maybe we should treat them in a lower level way, and the high rapid score patients, maybe we should be aggressive. That is the next key question. In fact, one of my fellows is trying to get a feasibility study funded to do exactly that. And there is no proof, it should be clear to the audience as of now, that you can triage treatment according to rapid. That's never been done. And an important thing for me and you to remember is that the low rapid score of 3% mortality is in the presence of current treatment. So you can't then say, well, this patient's got a low mortality regardless of what I do. No, that's not true. They've got a low mortality maybe because of what you've done, and maybe because of what you've done is TPA, DNAs, and then surgery. Who knows? So I think we can't use rapid to triage treatment as of yet. Now, to come to your actual question, which was, is this going to change who we put in the study? It's not, except that we will measure rapid score and we will absolutely minimize by rapid score. All that achieves is a balanced randomization by rapid group according to who has early surgery and who has TPA DNAs up front. And I think that's a really important question. If I had to predict the result, and by the way, in my career, every time I've tried, I've got it wrong. So I'm just going to put this out there. If I had to predict the result, I would say that the patients who have the highest rapid score potentially have the most to gain from early surgery, whereas the lowest rapid score, I suspect, have the least to gain. That's my guess. But I don't think my guess is good enough to say, let's exclude the low rapid patients. I think we put everybody in and we simply minimize according to the rapid score. If I just, final 5 seconds, the reason that I think that the highest rapid score patients have the most to gain is that those are the elderly, frail patients who can least afford to wait around for 3 to 5 days for TPA DNAs to work, for me to go and say, well, there's pleural shadowing, but your CRP is almost halved, and be a bit physicianly. It may be that those are the guys who need to get in, get the pus released, be sewn up after 48 hours with a good VATS procedure and get home quickly. At least that's my prejudice.
I was
if I
wondering, no, please.
though, sorry, I just wanted to quickly add to that and just say that I think one of the interesting things or observations for me, at least from MIST-3, was that the ages and the types of patients who were referred to surgery and had surgery. Sure, they were a small number, and that's I'm accepting and admitting that. But actually, I think we saw patients have early operations for empyema that in normal practice we probably wouldn't have seen, and I think I think that's important for us to show in terms of moving the needle, because I think there has always been a bit of maybe a bias in terms of our own practice, in that we feel that we as physicians know who the surgeons want to operate on or who can get an operation. But I think now, surgeons are operating on patients who are a lot older and a lot frailer than perhaps we might have thought. And VATS, at least our surgical colleagues, tell us, is a fairly straightforward operation, particularly for pleural infection. And actually, if as Nige says, there is this group of patients who have a lot to gain, I don't think, we should be denying those patients that. And I think the only way to do that is to do that in a trial in this unbiased way.
Yeah, I would agree with that. One of the things I would love you guys to comment on is in MIST-3, the time to intervention from randomization to IET was quite short, whereas time to intervention from randomization to surgery was 3.5 days. So the pleural space continues to evolve there. So out of those patients who had surgery, remind me how many had initial IET, and then also in MIST-4, ideally, once a patient's randomized to surgery, they'd go to the theater, right? So how are you going to try to minimize the delay in getting to the operating room?
So, Eihab, I'll take the methodology question if I may. I mean, I think, Dave, you're completely right as always. There was a 3-day delay, and that matters and it's important. But let's just be really sanguine about this. One, we have to do studies within the clinical reality of our practice. And that's the difference, as you know, between a clinical effectiveness study, which impacts praxis, and a clinical efficacy study, which is a technical. In the ideal world, if I could operate on you yesterday, you would have done brilliantly, etc. So I think that's an important distinction. The second distinction is that IET truly has an advantage in that if we decide, you and I, to treat the patient, we can treat them in the next 5 minutes. I mean, that is true. And we don't have to wait for operative capacity or them to be starved or whatever else. Now, to your point, MIST-3 was a UK study. Eihab and I have ambitions that MIST-4 can be an international study, but we were looking at the realities in the NHS. And the fact is, in the NHS, in general, if you're waiting for surgery, you can be waking up to 24, 48, 72 hours. That is true. But you are right that it would be a huge mistake to randomize people to immediate IET or wait 2 weeks for your VATS, because that's not a fair comparison then. So we've built in some methodology and design features of MIST-3 that will make sure that people get operations pretty quickly. So first of all, the 25 centers that we've recruited, we have a surgical co-PI who's going to talk to them about getting operations really quickly. We have, in fact, sold this to surgeons as a surgical trial, because it's actually a surgical trial and it's their opportunity to prove us all wrong. And I'm very happy for them to do that if they can operate quickly. So that's the other thing. And then finally, we have introduced a design feature, which is the physician-based clinical frailty score. So rather than, Ehab's made an elegant point, we shouldn't be making the idea that this one's not for surgery, this one is, but we are going to give a basic generic assessment that this patient, other than their empyema, is of decent performance status or good frailty score. And so we're hoping that the only screen patients are going to be potentially surgical. That combination then should allow us to operate on people fairly quickly. Eihab, did you want to take the first question?
Sorry, I forgot what the first question was.
Yeah, no, it was how many patients who underwent VATS in MIST-3 had initial intrapleural enzymatic
Yes,
therapy?
two of them, two out of the 10 patients who actually received knife to skin, and I think being a feasibility study, and especially I think we didn't want to be too restrictive. We are going to be tighter on that on MIST-4, and as Naj said, we have in discussion with our surgical co-PIs, hoping that will be easier to do now, aside from outside of COVID and all the rest of it as well.
May I just ask a question back, if that's okay, Andrew, just to yourself and Dave as US physicians. It may be that the parameters that we use are necessarily the ones that we see in clinical practice. We hope that our clinical studies have meaning to our day-to-day practice, and our day-to-day practice is in the NHS. I'm guessing that in the US, with potentially better access to thoracic surgery, at least in tertiary centers, as you guys both work in, it may be that actually it's much more possible to have a thoracic surgical intervention within 12 hours. Is that right?
At least in my experience, for most of these infections, most people are not in extremis to the point that they have to go immediately to surgery. Usually have some time to kind of triage them, start your intrapleural fibrinolytics and see how the patient responds. And usually in my experience, the surgeon will want us to give them at least 48 hours of a trial before kind of bringing them to the operating room. I think it's also, a safe point to bring up that, as you kind of mentioned, myself and Dave, we work in tertiary care centers where we have surgeons kind of readily available. There's different parts of the country where a surgeon is not going to be readily available, or you need to be waiting for transfer to a center with those kind of capabilities. So, I think the 3 to 5 days is probably, reasonable to say what would be a realistic time period between when a patient's identified and when they actually go to the operating room.
Yeah, I agree with part of that. I disagree with part of that. I think 5 days is too long. If you've made a decision to go to the OR, you should not be waiting 5 days to do that. That being said, at least in the centers where I've worked, there are two key variables. One is the surgeon. So we have some surgeons who say, "Oh, I'd love to operate after a couple of doses of intrapleural enzymatic therapy." The other surgeon would say, "Have they eaten?" Right? Meaning that they could take them to the OR that afternoon. The other factor is it a Monday morning or is it a Friday afternoon? Because if it's a Friday afternoon, they would almost certainly say, well, let's see how they do over the weekend.
That's a very elegant point, David. I agree. And look, if I can make just a slightly wider point, I think I've changed my thinking where this is concerned over the last 15 years of research in this area. Eihab and I about to prove that surgery is better than IET? Well, maybe, and that'd be great, right? The key thing is clean data and good data that tells us what the right thing to do for a patient is. To your point, Andrew, about the tertiary center, we also have the same issue that there isn't a thoracic surgeon in every hospital in the UK. There's about 40 thoracic surgical centers and about 200 hospitals, and they have a hub and spoke sort of referral pattern. If we go ahead and do MIST-4, and if we show that in any of these parameters that surgery is much better, which it might be, and I'm perfectly sanguine about that if that's the case, I think it completely shifts how we approach this disease. And actually, if surgery is clearly better, then you turn up to your district general hospital with a pleural infection, and the number one priority is to shift you to a surgical center, as opposed to let's get a tube in, let's give some enzyme, let's do a CT, let's blah, blah, blah. So I think Eihab made this point earlier, more elegant than I am doing now, but at surgery, we have pitched as a bad outcome. Actually, I don't think we should think that way anymore, that the outcomes that are important are not dying, get home on time, don't become too frail, get back to good life. And we're now at the position, I don't apologize for what MIST-2 or MIST-3 did. I think they were necessary steps. We're now at this position where we need to ask that direct question. What is the best treatment in the real world for a patient presenting with pleural infection? So we're finally at the edge of the precipice, and Eihab and I about to jump off. So yeah.
And I will say I welcome you guys also for taking moving the needle forward, and also not restricting the enrollment for this trial to people who are just fit for surgery, kind of taking all comers and seeing how they how they fared. At least some reassuring data. There was a study that just came out earlier this year. I know, Dave, you mentioned in your editorial, which actually looked at a U.S. center kind of enrolling these patients, showed very similar outcomes. It was also a feasibility study, single center in the U.S., but at least showing that you can get most people triaged into surgery or IET. So.
Yeah, I think that's pretty key. That Ehab's mentioned this in his great talk. The retrospective surgical data, amazing outcomes, minus 50% mortality because all the patients are 45 years old. And I can't remember the last time I saw a 45-year-old patient with pleural infection. They're all in their mid-60s, late 70s with multi-comorbidities. And the great damage of doing a beautiful study of surgery versus anything in a restricted population is that tomorrow, when I meet an 80-year-old, it doesn't apply. So we have to be, but there's some diplomacy required there, right? We need to help each other, physicians, surgeons, both of us together, to understand that this is a disease overall. We can't be cherry picking either of us. And there are clear advantages to surgery. There are clear advantages to IET, and we just need to work out what the best mode is. Yeah.
I'll pose this group not to anyone in particular on the panel, but in terms of how this trial was designed, how the MIST-4 trial is being designed, is that most people are getting 24 hours of conservative management before getting randomized to either surgery or IET. Are there any patients in your clinical practice where you kind of move that forward and say, we're going to immediately go to either surgery or IET?
Yeah, I think, Andrew, it's the minority. I'll just describe my personal practice, if I may, and then I'll love to hear from Eihab and David as well. I mean, we just released the 2023 BTS guideline, and in that we were very clear that there are a few patients who should be sent directly to surgery. My own practice is I like to think, look, what can I offer as a physician? I can offer sepsis control, I can offer some degree of source control, and I can get rid of the gunk using IET. All of that is true. The one thing I definitely can't offer is decortication. And so if you've got a lung that is very clearly corticated, on a CT scan, there's a huge rim of visceral thickening. And you and I and everybody else recognizes that, yes, we'll go in there with our expensive drugs and what we'll be left with is a trapped lung. Well, all that we're doing is delaying the inevitable, which is a call to the surgeon saying, can you decorticate, right? So I think if somebody's got very significant cortication, then I would send them straight to surgery. If they can tolerate it, I wouldn't even put a chest tube in because what's the point? And the other category is where they have completely solid looking pleural abnormalities. I'd advise a significant amount of caution there in terms of septations and ultrasound. I think a lot of people say it's septated, it's not going to work. I don't believe that's true for a second. I've treated lots of septated effusions very successfully with and without IET. But if it is truly solid on CT and ultrasound, well, my tubes don't move solid stuff. So those are the two categories that for sure we would go, but I wouldn't include them in the trial. I would just say this is a straight surgical candidate. They're not even eligible. Eihab, David.
No, I think you bring up a great point. And that was one of my questions for MIST-4 is, are you collecting pre-procedure ultrasound characteristics, i.e. degree of septation, visceral pleural thickening, things like that?
Sure. Yeah, 100%, David. And it's an interesting question in itself, isn't it? Treatment failure associated with septations. In fact, Ehab's other Blue Journal paper, which was on PI1 and septations, showed that septations did not, in fact, have an association with outcome. Again, big proviso there is that we're just saying there's septations at the beginning and there's an outcome at the end. What happens in the middle? Wise physicians, wise surgeons doing what they need to do. That's a variable. So I wouldn't say that septations mean nothing, but I don't think that you can say this is septated, therefore I'll choose this treatment. I think that's unclear as yet. Did you want to comment?
But I would also say that visceral pleural thickening is perhaps important as well.
Great, it's a great point.
Sorry, I completely agree. Yeah, I've got nothing to add to that. Yeah, perfect.
We have about 10 more minutes. Again, if there's any questions from the audience, please feel free to enter them to the chat. Otherwise, maybe just because we're getting to the top of the hour, Dr. Bedawi, Dr. Rahman, do you have any kind of final thoughts for the audience kind of moving forward, or at least what other questions do you see are unanswered and, even Ms. Ward may not answer it in the immediate future?
Yeah, I mean, we've got, sorry, you go first.
No, I mean, I guess the one thing that always comes to my mind is just we need to, I think we've kind of just got comfortable with a certain pathway or a certain type of treatment which is sort of a bit linear and sequential, and I really feel that if as a community that treats these patients we're really going to sort of shift the needle to improve outcomes, we need to start thinking a little bit differently, and clearly we need to change the paradigm that we've been using for the last 20 years or so in treating this condition, and probably longer. So I often when I'm having the discussion with my surgical colleagues, we'll get a pleural infection patient, we'll diagnose them stand away, we'll put a chest tube in, and then I'll come and assess them the next day if they're not getting better, and I'm making plans to start intrapleural treatment. I'll get on the phone at the same time to the surgeons. I didn't used to do that. I would normally wait 2-3 days, but I think that we have to realize that the time really does matter for these patients, and waiting 3-4 days to see whether intrapleural therapy works, then starting discussions to then wait another 3-4-5 days for theater is clearly making these patients waste away and get bad outcomes. And actually I think it's not unreasonable for us to for that surgical response that I'm sure a lot of us get, which is why don't you give some intrapleural treatment and then get back in touch. I think we have to kind of just come back on that and make sure that we're having those passing on those having those discussions daily and following up with those patients. And even when patients we have that perceived impression that they are getting better, we have to sort of really question what are we missing here, what's the advantage. Yes, sure, the CRP may have settled a little bit, but if there's a residual collection, the temperature may have settled, but if there's still a significant residual CRP and there's still residual collection, is that recovery going to go on and be protracted, with another 6 weeks of antibiotics? How long is that recovery going to take? When is that patient going to get back to their usual quality of life? So it's just, I guess that would be my final thought. Sorry, that was a long-winded answer, but it's just, I think as a community, changing that mindset, I think is really key, and getting our surgeons on board with that as well.
Thanks. Yeah, I mean, I agree with all of that, of course. Andrew, for my part, the bit that I'm interested in is becoming the harder outcomes like mortality. And I guess Eihab and I have done a lot of work looking at the past literature and thinking hard about whether we can do a mortality study. And here's the issue right here. There's never been a single comparative study that has demonstrated reduction in mortality with any treatment intervention, no matter what your surgeons say. So they will quote, oh, we've got case series, but we all know that that's selection bias. And my goodness, we've learned the hard way from the mesothelioma literature that if you select the right patient, they do beautifully well. So if you show me a case series of 40-year-olds, well, I would absolutely expect the mortality to be low in a bunch of 40-year-olds, right? And then we do placebo-controlled randomized trials in all comers, like MIST-1, like MIST-2, MIST-3, and consistently we're getting mortalities of 15, 16, 18%. So I think it's MIST-4 will be interesting in this regard. Of course, we'll look at mortality. And of course, to your previous question, we'll look at it in the highest risk categories by treatment arm, which will be really interesting. But as yet, has anybody proven to me that surgery saves your life beyond other treatments? No, that's not been proven. Now, I should be forgiving and say that when I fail as a physician, which is regularly, then I ask my surgeon to get me out of trouble. That's not quite the same thing, though. And so I think there's some really interesting questions in that hard outcome area about mortality and can we shift the dial, as Eihab has said. I think there's also a lot of biological translational work that's needed in this disease because it's a complex disease. This is not pneumonia that's a bit wrong. This is way beyond. The mortality is 5 times as high and the outcomes are much more poor. The microbiology is very mixed. The intrapleural environment is not just a sepsis environment. It's a fibrinolytic, immune suppressed environment. There's loads of really interesting stuff about how we get to the point of having established pleural infection. And then once you've got it, what you should then do. So I think any keen researchers in the audience be delighted to receive an email. There's lots of stuff that we need to do.
Yeah, I really have nothing more to add. You guys are quite eloquent, and it's a really exciting time. As you said, we're at the precipice of really defining what the best treatment is going to be for our patients. So, this has been going on, gosh, since the time of Hippocrates, right? 2,000 years, and you were going to solve that question. So this is huge.
Well, if we have a good recruitment graph, we'll solve it. Yes.
Yeah.
All right. Well, I'm going to say we're at the top of the hour. So I want to thank, again, this esteemed panel for joining us today and kind of talking about the research and where they're moving things forward. Dr. Bedawi, Dr. Rahman, again, thank you so much. Congratulations on the paper, and we look forward to seeing the results for the MIST-4 trial. And Dr. Feller-Kaufman, thank you again for joining us today. So as always, this presentation is going to be recorded and available on the ATS website. Under the clinical problems webinar committee. If there's any suggestions for papers to discuss in the future, please feel free to email them to myself or one of the co-editors. Our contact information is on the website. So again, thank you so much for everybody, and have a good rest of your day.
Have a great day.
Thank
Thanks,
you.
guys.
Take
Bye.
care.
Yep.
Thanks, Andrew.